Good morning. This is Dana Parsons with LeadingAge Virginia and wanting to welcome you to our Coronavirus Weekly member update. Thank you so much for taking the time to be on. We would like to begin our update today with Matthew Mary from the Virginia Hospital and Healthcare Association. So over to you, Matthew.
Hey Dana, can you
Okay.
hear me okay?
Yes, please.
Excellent.
Go ahead. Thank you.
Yeah, so thank you all for including us today. As of April 22nd this morning, our hospitalizations with confirmed and pending cases has went up slightly to 43 at a total of 1,374. Current COVID isolation ICU hospitalizations have went up slightly to 419. Along with COVID hospitalizations on ventilators, has remained relatively steady. And the good news, total COVID-19 discharges continues to go up as well. And so the numbers over, especially the last week or so, have remained quite steady on the hospital side. Some supply chains have started to open up ever so slightly. And then on the long-term care side of things, I definitely want to give a huge shout out to all long-term care facilities and your dedication to reporting within the VHOS system and the support of LeadingAge. Yesterday's data out of 287 facilities, we had 82% of those facilities reporting their data, which is incredible. Confirmed cases continue to go up across the Commonwealth, again remaining in the eastern, central, and northern regions, and the northwest region again has continued to go up since last week with number of cases, and that's mostly in the pending category as of right now. So with that being said, the big ask from the Hospital Association is our coalitions and us at the Hospital Association, along with VDH, are pursuing every avenue we possibly can for PPE. And I would recommend that you continue to utilize the VHOS system. To note, we did make an upgrade over the weekend, and under clinical operation status, it does have a PPE question. Do you believe you have enough supply within 72 hours? We added which supply specifically you are in need of, as most facilities aren't in need of necessarily all PPE, but we have noticed a huge influx in the need, especially in the long-term care communities, of gowns, along with obviously the face mask and such. And so this data is quite valuable for our healthcare coalitions to get an idea. It's also data that we can push up to the state level to VDEM in hopes of securing more PPE at the regional level. Continue to support long-term care facilities to call your healthcare coalitions. Reach out, as they are keeping track of these needs within your facilities, especially those who are greatly impacted with residents with pending and confirmed cases. So that's all we have at the association there, Dana, and I'll feel free if anyone has any questions to take them at this time.
Yeah, I wondered if any of our members have any questions regarding that upgrade to the VHOS system, if they could put those in the chat room. Okay, well, we appreciate that update. Thank you so much. At this time, I don't think we have any additional questions, but we hope that you can remain on in case any questions come up as we continue to talk today. So thank you so much.
Thank you, Dana.
Thank you. Want to talk now about the Virginia Department of Health lessons learned from Sarah Feil-Leinberger. Over to you, Sarah.
Sure, can you hear me?
Yes, we can.
Great, good morning, everyone. Thanks for all the work you're doing. Just to give you some updates, as of this morning, we have 159 outbreaks of COVID-19 in Virginia. Again, an outbreak is defined as 2 or more cases in a facility, and out of those, 85 are in long-term care facilities, including skilled nursing facilities and assisted living facilities. So we know many of you on this call are responding to outbreaks, and we so appreciate all the work that you're doing. In terms of case counts, we have over 9,000 cases as of yesterday, and we actually had a glitch overnight, and the actual case number won't be updated on the LeadingAge website today. But we're over 9,000 cases as of yesterday. A couple of things I wanted to highlight. We are moving forward with providing more point prevalence surveys in long-term care facilities. Sometime this morning, prioritization for point prevalence surveys is being posted on our website, and that will include skilled nursing facilities and assisted living facilities under priority 1 for that testing. In addition to our public health lab, DCLS, we are working with UVA and VCU hospitals to have that testing capacity to do that testing. Just to talk about point prevalence surveys a little bit, it can be used to identify the number of people with COVID at a specific point in time in the facility. Ideally, residents and staff will be tested. However, facilities really need to think through what you would change in your facility or how you would react to positive results. I think I've mentioned that for some of these point prevalence surveys we've done, we've had a very high percentage of folks positive when we've gone in and tested. And if staff are tested, which ideally they would be, then if you have asymptomatic positive staff, you will need to have plans, ideally to furlough them, unless you're in a crisis situation with staffing and just absolutely don't have enough staff to cover the facility. But those are the kinds of things to think through before your facility does a point prevalence survey. A point prevalence survey doesn't give you all the answers. It really raises more questions. It can give you data on what's happening in your facility, which can be helpful, but you'll have to react to that data and make decisions. So we'll have more guidance coming out, but I'm happy to take questions about point prevalence surveys, and we're working really hard to increase capacity for that and have been doing those across the state. And then another thing I wanted to mention is I know you all have been asking a lot about sharing information between facilities when there are cases or outbreaks, and there is movement on that. Dr. Oliver did approve that, and there was a media release this morning that long-term care facilities can share information on positive cases across facilities in order to help with case identification and contact investigation efforts, basically because there's a public health reason to do so, to help with these outbreak investigations. So one nursing home could share information with another nursing home on positive cases. So those are my main updates for today.
Thank you so much, Sarah. We do have some questions, so over to you, Melissa.
Thanks, Dana. One of the questions that came in, Sarah, was if a member is the full continuum, so independent living, assisted living, and SNF, will testing be done in all levels of care?
Sure, it's a good question. Those are the types of conversations that will just have to happen at the individual facility level because every facility is different. So a point prevalence survey doesn't necessarily need to happen in the whole facility if you think that cases are confined to a certain part of the facility or a certain unit. So it might just be a point prevalence survey is done to test everybody on that unit, for example, in a continuing care retirement community or something like that. You know, you might not have cases, or there might not be a reason to test in part of the facility. So a point prevalence survey isn't necessarily designed to go in and test the whole facility. If there's a reason to test the whole facility, then yes, we would facilitate that. But in some of these situations, we would only test in part of the facility or part of the levels of care. Does that make sense?
It does. Thank you. And what are the criteria for asymptomatic positive staff to return to work?
Sure. It's a good question. And you might have seen that CDC has updated some of their guidance on this. I'm trying to pull it up. So there's the test-based strategy and the non-test-based strategy. And for healthcare workers, CDC is really recommending using the test-based strategy for return to work. And so that hasn't changed. And so that would be that symptoms have resolved and then that there are 2 negative tests for that staff member. The non-test-based strategy, if testing isn't available, is where we get into the 7 days have elapsed and at least 3 days without symptoms. However, with increased testing, we are really recommending using the test-based strategy to test healthcare workers and try to get them back into work.
So if they never had symptoms, it's the 2 negative tests then?
No. What I just mentioned was if they have symptoms. If they haven't had symptoms, that's where CDC has changed the language a little bit. If they haven't had symptoms, then they've changed it to needing to be 10 days. So if they've tested positive and they didn't have symptoms, CDC is saying 10 days.
Okay. All right. Thank you for that clarification. Another question that came in is, why is VDH increasing testing of inmates at correctional facilities but not residents at long-term care facilities? And they're citing a press release that came out.
The way we're prioritizing testing is that long-term care facilities are our first prioritization for point prevalence surveys, and correctional facilities and related facilities are the second priority.
Great. Well, thank you, Sarah. Those are all the questions we had, and we really are appreciative that the Department of Health is going to issue that press release today. I know that you've put up with us, Dana and I, bugging you all about that, and we really, really appreciate it's going to be a move in the positive direction. So thank you for all your hard work.
Sure.
Yes, Sarah, thank you so much. And I wanted to also give you an opportunity based on any of the questions that have come in. Did you have any other information that you wanted to share?
I think I answered all the questions, and I'm happy to share the press release because I think that did already go out this morning. So I can add that to the chat. But no, that's it. Thank you so much.
Okay, thank you. You can share that with me and I'll make sure that's in our update today. So thank you so much.
Great.
Thank you. Thank you very much. We are going to move on and talk a little bit about the governor's long-term care task force that he convened to focus on long-term care issues related to COVID-19. We are privileged to serve on that task force and are so happy that we have several members: David Abraham from Beth Shalom Village, Greg Storr from Williamsburg Landing, and John Burns from Westminster Canterbury Richmond, along with Melissa and I, are serving on that. We also have a smaller provider group that has been convened that's discussing some focused issues that the task force is addressing. And Allison Zuba from the Adult Care Center in Central Virginia, Libby Bush from Vincent Hall, Mo Funk from Beth Shalom Retirement Community, and Robert Atkins from the Masonic Home are serving on that committee, and they will be talking with you a little bit later about that. So the Long-Term Care Task Force had its first meeting virtually on April 16th. The charge of this task force is basically to ensure a unified state government response in supporting long-term care communities in responding to COVID-19, as well as facilitating better data collection regarding COVID-19 to foster communications between providers and the Department of Health and the Secretary of Health and Human Resources, as well as the governor. Some areas of focus are data, staffing, financing, testing, PPE, infection control, and hospital discharge planning. Our next meeting is going to be tomorrow, and we will have asked our representatives who are serving on the task force to take on areas of focus regarding staffing, testing, infection control, and all that I mentioned to address on the task force related to those issues. And if you have any questions about the task force, if you could include those in the chat box, but I'd like to hand it over to Melissa now to provide some additional remarks.
Thanks, Dana. As Dana mentioned, the task force is dividing. It's a pretty large group, so they're dividing into 5 work groups, and we will have a representative on each of those work groups. So Greg Storer will serve on the staffing work group. David Abraham will be on financing. John Burns will be on PPE and infection control. Dana will be on discharge planning and coordination, and I'll be serving on communication. So as those work groups begin to convene, we will always include updates in our daily update so you will know what's happening. But if you have anything specific that you want to make sure we raise with either those work groups or the General Governor's Task Force or our smaller provider group that's meeting with Dr. Forlano, please make sure that you email those questions to Dana or me, Dana@leadingagevirginia.org or Melissa@leadingagevirginia.org. We want to make sure that whatever is on your mind, we are able to share. I know there are some consistent themes whenever we have these conversations and on different topics, but we also know that things are different in different regions. So just keep the channels of communication open with us so that we can make sure that whatever challenges you're facing in your part of the state are raised with the task force. Dana?
Thank you, Melissa. Now, Greg Storer, if you could please provide us some of your perspective and your participation on the task force.
Well, good morning. Can you hear me?
Yes, we can. Thank you.
Good morning. Well, thank you. First of all, I want to commend the governor for putting this task force together and thank LeadingAge Virginia leadership for getting us a seat at the table. I thought it was a really good first meeting. As Melissa mentioned, there are a lot of organizations that cover the entire spectrum of healthcare that are part of this. I felt a really strong sense of camaraderie and working together. I think evidence for me, I was really glad to hear this morning that the press release coming about sharing data amongst communities who might have positive cases. I know that came up and was discussed quite in depth at our first call, and to see movement already happen within a week, I think shows a commitment, at least to me, that this task force really is interested in making sure that we all have the resources and the ability to work together, not just as communities, but as organizations, to make sure that we do the very best to keep our residents and our employees and staff safe. So I'm happy to be on the committee. I do want to emphasize what Melissa just said. Please let us know if you're having issues or would like us to raise any issues with the task force related to any of the areas of focus. I think we'll be extremely successful when we hear from our members so that we can address on a weekly basis with the task force the issues that we're all having. So I think the first meeting was a good meeting. I'm very excited about where we're at and the possibilities that we have in the future.
Thank you, Greg. Thank you so much. Libby, over to you to provide us some perspective on our call with Dr. Forlano. Libby, you may be muted. Okay, well, this was an opportunity that we had. I'm sure Libby will join us when she can to speak with Dr. Forlano with the Virginia Department of Health with a small call with providers, including the Virginia Healthcare Association and the Virginia Assisted Living Association, along with LeadingAge Virginia, to talk about member provider perspectives on some of the issues that they are dealing with during COVID-19. We really appreciated the opportunity to speak directly with Dr. Furlano, for her to hear from our members about how they're being impacted and what their needs are. Melissa, did you have any thoughts on or remarks about the call that we had?
Just that, it's in some respects it's good we're all in the same boat. In some respects it's not. I mean, there's so much consistency in terms of the challenges that providers all over the state are facing. And, just with appreciation that Dr. Furlano and her team are aware of the challenges. They are really being intentional with their approach to this work. I spoke to Dr. Furlano again late in the day yesterday, and these folks are really come up to speed as quickly as they can. They really care about our communities, our providers, and so they're being wonderful allies as we approach this work. And I think that that it's nice to have this smaller venue where you could hear directly from our members around what their challenges are, so that they can hear directly from the members. It's one thing to hear from you and me, Dana, but it's something else to hear from people who are living this day in and day out. So I think that is that's all positive. And Libby is here. So Libby, would you please chime in on your perspectives with the call with Dr. Furlano? Thank you. You might be muted, Libby. Well, we're waiting for Libby. We had a question come in, Dana, which is funny. The question is, where do we think Virginia stands in comparison to other states in our response, in particular testing, transparency, and PPE? I have not been asked in all of my conversations with journalists to give my perspective compared to other states. I've only been asked what I think of or what LeadingAge Virginia thinks of the state's response. I think that, and then Dana, I'll ask you to chime in here, please. I think that we are uniquely positioned because our governor is MD. And so with his vast medical knowledge, he understands really what our members are facing. I think that we can't just look at our state's response. We also have to look at the support from the federal government and kind of what that relationship has been to really understand the full scope of Virginia's response, because, early on we were relying on testing coming from the feds. And I think that this press release that the Department of Health is releasing around transparency between providers is a wonderful step in the right direction. And as Matthew said earlier, we, now we're hearing that gowns are the big issue from our members, as well as other forms of PPE. So I think that it's constantly evolving. Dana, what would you add to that in terms of Virginia's response versus other states?
Yeah, absolutely. I agree with all that you said, Melissa. I think that we are unique in that we are an example for other states as far as having our VHAS system and our Virginia Regional Healthcare Coalition system in place prior to this crisis, so that we were able to be up and running and having our coalition to reach out to so that they can understand our testing and PPE needs. I feel that we are uniquely positioned in that we have direct communications and quick responses from the state. As you can see, having Sarah Lineberger on the call, having the Hospital Association, we are very fortunate that we're in constant communication with these entities about the needs. And as far as comparing to other states, it's hard to really gauge that. But I know that Virginia has been a positive example for having our VHA system and Regional Healthcare Coalition system in place that's been working so well to respond to these issues.
Libby, are you here? Because I do have a question for Sarah if you're still on the line. So, Sarah Lineberger, are you still here? Maybe not. Okay. The question, and this did come up yesterday on one of our calls. It's hard to keep them track. Dana, do you remember this? Are other assisted living facilities creating isolation apartment areas?
Sorry, can you hear me now?
Yes, Sarah, thank you. The question was, are other assisted living facilities creating isolation apartment areas if able? I feel like this came up on one of our calls yesterday.
Yeah, that's a great question. I mean, we recognize it's a lot more challenging to move folks in assisted living facilities. I do think some assisted living facilities, or at least like corporations with multiple locations, have designated parts of like an empty building or a wing, somewhere where they don't have to move somebody out, but where they have possibly some extra space or something like that as an area to care for positive residents. But we really don't worry quite as much about rapid spread in assisted living facilities where there are individual apartments, because they're better able to social distance. I would say the thing to think about is staffing, and if you can designate staff to work with certain residents so that staff aren't going all over the building. Again, I know that's hard, and some of those are facility by facility discussions. I think it's great that you're thinking through that, but we recognize it's harder to move people in assisted living.
Thank you, Sarah. I'm scared to ask. Oh, there she is.
Can you hear me now?
Yes.
Oh, I'm so sorry.
Good morning, Libby.
I apologize. Our new world of conference calls. Okay, the only thing that I would add to Greg's excellent words, and of course everybody else, my appreciation to Dr. Furlano. Again, she not only did I hear we're all in this together, we're learning together, humility about creating consistency across the Commonwealth with local health departments, but also such responsiveness. And let me give you an example. We asked for a waiver for cohorting our current positive residents, and we had disconnect between the local, county, the state, and then the federal authorities. She helped yesterday in the background maneuver that. So the response to my comments on the call yesterday, frankly, was immediate. So I am very encouraged. I think you used that word, Greg. I'm going to share with you all, because you talked about everything we talked about on the phone. I look forward to sharing with this team how we can highlight our long-term care, life plan community frontline workers, and others like they're being highlighted in the news with acute care. We sorely need that to happen regularly, consistently, and wave that banner high. So I look forward to more of that. And then, of course, communication, transparency. We know from CMS, we heard from them, I think last night, that we have our new requirement, as I'm sure was mentioned earlier. That's it for me, Melissa. Again, thanks for persevering.
Well, thank you for persevering to be able to talk to us today, Libby. That was a battle in and of itself. And you just figured something for me, Libby, that I just want to add, Dana, and then I'll be quiet. I'll try. Is that, the positive stories that you have in your communities. I hope you saw in the daily update yesterday the wonderful story of a resident of Beth Shalom here in Richmond who is 90 and came home from the hospital. And there was a beautiful story that her daughter gave to the press around just how wonderful the response has been from Beth Shalom and the engagement with staff and all of that. And so if you have bright spots to share, please take a few minutes and send them to me, Melissa at leadingagevirginia.org. I have been really pleased that so far the media has mostly been given I should just say they haven't been really negative on nursing homes and long-term care providers as they have been in other states, but we need an arsenal of bright spots, of positive stories, as we continue to talk to the media and raise the visibility of the fact that our members are on the front lines just like hospitals. And so we want to make sure, as Libby said, that we are sharing those positive stories, that we are getting ahead with our messaging. So please, as you have those, send them to me. And how can members access the repository of bright spots? Well, once there is a repository, we'll be sharing those. So we'll be posting them on social media. We're developing a media toolkit for our members to use that should go live by Friday. We're also doing our Share Your Heart campaign to thank members and frontline workers. And then we'll be doing, we hope, some op-eds that can be customized, asking our members to share those with their local papers, that can include some of those bright spots. So this is new work for us, and we welcome any of your talents that you could aid to that. And so thank you for that. I just see a comment from Glenn that echoed what Libby just said, and want to reinforce that we highlight all of our frontline staff. His daughter works in food service, and last night expressed that she felt unappreciated at the place she works, has only been celebrating nurses. So absolutely, Glenn, it's about everybody. I mean, housekeepers, those in dining services, maintenance. I mean, just they're everybody. And then another question came in: how are communities reporting to your stakeholders and regulatory bodies when a COVID positive resident passes either in your community or at the hospital? Sarah, I wonder if you would mind taking a first stab at that question. How are communities reporting to stakeholders and regulatory bodies when a COVID positive resident passes either in their community or at the hospital?
Well, this is Dana. I can comment on that. We can get some more information, but our understanding is that there are reporting guidelines in place. The Office of Licensure and Certification is requiring that you provide a FRI to them to keep them informed. The Department of Social Services, I have to check on that, but we can certainly provide that information for everyone in our update today once we can get an update on that. Melissa, did you have any more that you would like to share?
No, thank you, Dana.
Before we move on to our next update, I just wanted to mention that today was our day to storm the Capitol. So I miss being with many of you, walking throughout the halls of Congress to talk with them about our issues. So in light of the fact that we are not able to do that, we do have a National Day of Action for Aging Services. So if you could please go to our social media outlets and send a message to Congress and asking them to provide critical funding and resources for aging services, including nursing homes, adult day, just every level that's possible. We need messages sent to them. This advocacy alert will also be in our daily update today. So hopefully we'll be back together on Capitol Hill next year. But with that, we have a lot of things happening with CMS, and we're very fortunate to have Jody Agor with LeadingAge to join us. So over to you, Jody. Jody, you may be muted. Okay,
Yep,
thank you. We can hear you.
Sorry about that. And thanks for having me on the call today. So yes, CMS has been busy and is holding us up a little bit with how busy they are. They announced over the weekend that there will be forthcoming some new reporting requirements for nursing homes. This was announced in a memo on Sunday evening, but the rulemaking is not out yet. And that's why I say that they're holding us up a little bit, because the rulemaking is when the requirements will actually go into effect. And it is, unfortunately, the most information that we're going to get. We are trying to get more info from CMS and CDC at this time, but what CDC told us on a call just now that I joined this call from was that a lot of the information really needs to come out in that rulemaking. So Glad for the clarification, hope for some actual details soon. But nursing homes, from what we learned from this memo that came out, nursing homes will be required to report directly to CDC about COVID-19 and will be required to notify all residents and resident representatives of the facility's COVID status, and that there could be enforcement actions taken against the nursing home for failure to report to CDC and failure to notify residents and families, residents and their representatives in a timely manner. And we note that this is in addition to existing requirements that nursing homes need to report to state and local health department for any of their infection control requirements, and then also that they need to be notifying residents and their representatives of individual health status and changes in that way. We were a little surprised, and we have some concerns about these announcements, which I'll get to at the bottom. But I wanted to first talk about the resident and the resident representative notifications. So the guidance tells us that nursing homes will be required to report to residents and representatives within 12 hours of a newly confirmed COVID-19 case or a cluster of illnesses. And we are seeking some clarification around cluster, because in the guidance, they refer to cluster of respiratory symptoms, but our understanding was that this requirement would actually go along with the all other infection control requirements around clusters, which is a cluster of actual illness. I know there's been a lot of concern about respiratory symptoms can pop up for a number of reasons, including allergies, and it is allergy season. So we will be getting clarification on that as soon as we can. Nursing homes are required to also report to residents and representatives on a weekly basis. The understanding is that that weekly basis is in case you're not weekly confirming new cases. So maybe you get a new case once a month, but your residents and representatives still need to be updated on what's going on. So that's where the weekly requirement comes in. And that when you are making these notifications, you're including information on the actions that you have implemented to reduce and prevent the risk of transmission. And it's important to note that these notifications and the reporting to CDC include both resident and staff infections, not just the resident infections. And when you're counting your clusters, that you're counting both resident and staff cluster in that cluster. So the reporting to CDC, we know that it's going to be done through the National Healthcare Safety Network System, NHSN. Some of you may already be reporting your healthcare associated infections through NHSN right now on an optional basis. CDC is working on rolling out a COVID module that's specific for long-term care. And CMS has made the requirement that this module needs to be used for nursing homes, but I do note that the CDC's module allows for both nursing home and assisted living providers to report through this same module. CDC is really, really wanting to get the information from assisted living, but CMS doesn't have that federal authority, and so keep an eye out to see if your states will be requiring that your assisted living is reporting through the NHSN. The guidance says that CDC will make this data available to health departments, to HHS, and may publicly report on the data. We're not entirely sure yet how it would be publicly reported or how that publicly reported data would be used. We know what CDC is going to be using it for. They're using it to support surveillance, to inform policy and decision-making, to inform decision-making around PPE in particular, and to help track and basically learn more about this disease so we can be more effective at battling the disease. We had previously reported, based on a little bit of miscommunication, that you could either enroll or submit directly on the website, but we just learned on the call we came off of, so you, Virginia, are the first to hear that all providers will need to enroll in the NHSN network, but they are working on an expedited enrollment process that will not include an identity verification. So providers will have the option of doing just the expedited enrollment or a full enrollment that includes identity verification. The full enrollment takes a little bit longer, but it does give you access to more information, like some benchmarking data, so that you could potentially use it in your quality improvement programs. it is seeming to be quite a heavy lift on the reporting compared to what we're currently doing to health departments. We are going to be working with CMS on this. CDC has put out the data elements for the information that they want to collect and that they feel is necessary to collect. But CMS is the one who has the authority to determine what's required and what is just an optional collection. So we were at LeadingAge, we're a little bit, not a little bit, we're quite fired up about the duplicative reporting because we understand that this is a really tough time. And the last thing that anybody needs is to be penalized and to receive enforcement actions against them because they reported in one place and not a second place, or they reported to the health department and then they reported to CDC, but the information that they reported to CDC wasn't conclusive enough or didn't include enough information or accurate data, and they're getting penalized for that. So we have done some advocacy around that. We sent a letter to Secretary Azar and to Administrator Seema Verma yesterday evening to express our concerns and to ask for some addressing of those issues, and we will be following up with CMS directly on that. And hopefully, as this information becomes more available, we can roll out more for you. But again, it all really is based on this rulemaking that we're waiting on, and we don't know when that rulemaking will come out. And I don't even know that CMS can tell us at this point when it will come out because it's kind of tied up in all of the bureaucratic avenues.
Thank you, Jody. Thank you for that information. Very comprehensive. We really, truly appreciate that. Are there any questions for Jody?
No, but we're excited to be the first in the nation to hear that sneak peek, Jody. Thank you for rushing off that call for us.
Yeah, so happy
Thank
to
you.
share it with you. And we will preview on our daily call this afternoon. We'll be sharing that information as well.
Oh,
Perfect.
great. Okay, well, before we end our call, are there any issues or anything anyone wants to discuss? If you could put those in the chat box before we hang up. While you're doing that, I would like to let you know that our next weekly member call is going to be on April 29th at 11 a.m. So we look forward to talking with you. If you have any topics that you would like to have addressed on our next weekly call, if you could please send those to Melissa or me, that would be great. But not having any questions coming in, we will go ahead and end our call and want to thank our presenters and all of our members for being on today, and look forward to talking with you next week. And you all are continually in our thoughts and prayers during this difficult time.